Thank you. I will try to make this short and sweet since it's only 7 o'clock in the morning here in Boston, but happy to see you all again. And I'm sorry I couldn't be there in person. I want to talk to you about the VHIT 3 study. These are my disclosures. I work with many companies that develop new products for treating ITP. I mentioned yesterday that the B cell activating factor BAFF is necessary for B cells to live, and this is the B cell receptor here. BAFF is over here. There's a very complex signaling pathway with BAFF being necessary for the viability of B cells. And so it's a very interesting receptor. It does many things. And basically, if BAFF is activated, B cells live. If BAFF is not activated by either getting rid of BAFF or blocking the receptor, we have B cells that don't seem to work. But it doesn't affect all lymphocytes. It only affects, sorry, it minimally affects pro-B, pre-B, and other miniature B cells. Its major effect is on memory B cells, particularly in knockout mice. It is a interesting condition, and as I said, BAFF levels are elevated in many patients with autoimmune diseases. This is a very old study from our colleagues in China that showed BAFF is elevated in patients with active ITP, becomes less activated, and back to normal in patients with ITP in remission. There are many other studies describing BAFF being present in large amounts in autoimmune conditions of many different types. The VAY736 and its inalumab is how the drug is named and pronounced. This is a monoclonal antibody. It is an interesting antibody in its structure. It's fucosylated, which makes it give some interesting attributes. It binds here to the BAFF receptor shown here. It causes NK cells to conglomerate around them, and like rituximab, clears the B cells. In addition, it blocks the BAFF receptor shown here. Here's the BAFF receptor, here is BAFF, and here's the antibody, and it prevents B cell differentiation and proliferation as well as survival. So the expectation when one uses adalimumab is it will deplete B cells physically and also inhibit their production of antibody and make them less reactive. The VHIT-3 study, and I think there were some people in the audience that participated in this study. We screened patients with ITP, platelet counts under 30,000. They who had a prior response that was not maintained. They were given inalumumab. This is 4 doses given every 4 weeks as an IV administration, 9 milligrams per kilogram. So it's a standardized dose for this and a wide range of other studies. Patients were then assessed at week 25. This is a non-randomized study, no control group here. Patients who had efficacy could continue to receive further treatment. All patients were followed up for another 24 months for safety and efficacy. We enrolled 41 patients in the study. They completed 4 infusions in 38 patients. The primary endpoint was assessed in 39 patients, and we've got about 26 patients currently in the safety study, and 13 entered the long-term efficacy follow-up study, and this is the responder long-term assessment. Who are these patients? Well, they're typical patients with ITP. They're middle-aged. They are a little bit equally distributed male and female. They had a median platelet count was quite low, 8,000. These patients were pretty heavily treated. They'd had a duration of ITP for a median of 4.2 years. They'd received a median of 6 prior therapies. Prior medications included corticosteroids, TPRAs. The list is typical to many other studies that we've done. So this is a highly treated long-term ITP patient, and I don't like to use the word refractory, but that's been commonly attributed to this kind of patient group that we studied. The primary endpoint is a rather easy endpoint. We're platelets 50,000 on 2 consecutive assessments between weeks 1 and week 25 in the absence of rescue therapy. This is called a confirmed response. This occurred in 44% of patients, and the median time to response was 6 weeks. More stable response, meaning more than 50,000 on at least 75% of assessments between week 19 and 25 in the absence of rescue therapy. This occurred in 24%. And what's interesting is that 9 of the 10 patients that had this stable response had a complete response at week 25. So these are exciting results to me in patients who have a rather bad disease. Now, as typical in many ITP studies, we then try to cut the pie a different way. We then use the IWG response criteria, which lowers the platelet count a bit, both for the response and for the stable response. So simply we're dropping the platelet count to 30,000 or 50,000. This raises the response, two consecutive responses to 49%, and the stable response rises a bit to 27%. So this is a pretty confirmed diagnosis in terms of the patients with ITP. So this is a decent response rate in these patients. If one looks at the platelet count, the responders are shown here. They start to rise rather rapidly with week 3 or 4 and continue to increase over time to week 29 of study. The non-responders, again, there are a few left at this point here, don't have any change in platelet count. So basically, we've got 18 responders, 23 non-responders. What's also interesting here is if you look at any grade bleeding rates on the WHO scale, this decreased from 59% at baseline to 22% and then to 10% in those patients who responded. So in addition to a platelet count response, bleeding events, which I don't show here other than in the statement here, declined. What about safety events? Again, adverse events were seen in almost all patients. Drug-related adverse events were about 35%. Serious adverse events, 6 patients. Felt to be drug-related in none, no fatal responses. Patients did not have to discontinue therapy. The types of adverse events are familiar to all you that do ITP studies: headache, contusion, petechiae. There are a few infusion reactions which are very low grade, grade 1 and grade 2. Now, if you look at adverse events on treatment as serious adverse events and adverse events of special interest, the all-grade adverse events, again, we always add thrombocytopenia here, which is a bit silly, but that was seen in most patients. Allergy to the therapy, minimal. CKD, minimal. Liver disorder, minimal. GI hemorrhage, minimal. These are all reasonably low-grade effects. The main concern about infusing antibodies is infusion reactions reported in 6 patients. They're all grade 1 or 2 and did not require any specific therapy, and they did not result in discontinuation. And finally, infections are in 37% of patients. 1 patient had a grade 3 infection, which is a C. diff infection, probably due to other medical problems which he had. I'll comment upon the fact that 1 patient died post-treatment due to pulmonary edema. This was felt not to be related to the ianalumab, but the patient's prior cardiovascular issues. Finally, and this is my last slide, what's interesting about this drug, and I don't have the data to show you, I'm not able to give that data yet until our publication comes out, there is a rapid decrease in B cells after the first infusion. For example, if you looked at the median percentage of change from baseline, 97% at week 5 and 99% of patients had a decline, a massive decline in their B cells. This is like rituximab. There was a sustained B cell depletion with a median percentage change of over 95% from baseline at week 29. So not quite like rituximab, but more potent than rituximab. We have massive B cell depletion week 29. What about antibody levels? What's interesting is the IgG antibodies, which are shown here, did not decline significantly over this time of study. So to summarize, this is an interesting novel new agent for ITP. It's 4 infusions once a month for 4 months. The question that I'll raise to our audience here is whether this is going to be better than rituximab and provide a longer-term remission. It certainly has a decent high rate of remission in patients with late-stage disease. And that'll stop, and happy to take any questions.
Thanks, Dave. Thank you so much.